project, I would say, in this area. So I'm going to talk around implementing ultrasound-guided regional anesthesia a little bit, and also implementing regional anesthesia, because without implementing regional anesthesia, you're not going to be able to implement ultrasound-guided regional anesthesia. So just to summarize the talk, for those of you that wanted to get the quick 5-minute summary before you go to sleep and wake up at the end. So in the next 20 minutes, I'm going to talk about the fact that the evidence base for the use of ultrasound is very strong. There's no doubt that if you're going to do a regional technique, you should probably, for many of the techniques, you should be learning how to do an ultrasound-guided regional technique. The main barriers to current use, I would say, include training, because we've got two types of practitioners out there. We've got practitioners in training who are trying to get training in lots of different areas, including regional anesthesia and ultrasound-guided regional anesthesia. And then we've got practitioners in practice that have maybe had some ultrasound, or have maybe not had any ultrasound training and are trying to catch up with that. So how do you do that? The availability of equipment is obviously important. And then the environment being conducive to learning and practicing regional anesthesia and ultrasound-guided regional anesthesia is very important. So one of my colleagues from Dundee in Scotland, Tony Wildsmith, bit of an advocate of regional anesthesia for those of you that know him, but one of his important quotes is, "It's only when all knowledge and skills have been acquired and are applied with much attention to detail that regional anesthesia can deliver its potential to make patient care better." And I think that's very, very true. If we're going to be doing any of these techniques, we need to be competent in those techniques. Otherwise, we really are going to be doing more harm than good. And the old adage of first, do no harm, I think rings very true. So what about training? Well, really, there isn't really an evidence base to guide training at the present time. There's a lot of expert opinion as to what constitutes adequate training in ultrasound-guided regional anesthesia, but there's a few studies coming out in the literature. In fact, we're just having a look at some of those now, but there really are no formal training guidelines that are based on any evidence base to help us know how many blocks to do for different techniques, et cetera, before you can really regard yourself as adequately trained. And I suppose you could probably say that's true for many areas of medicine, not just ultrasound-guided regional anesthesia. Although there are many groups around the world now starting to try and look at these things. Certainly in Toronto, at Toronto Western Hospital, we're doing some studies at our centre, and other centres around the world are starting to look at training and how to train people in the best way possible for ultrasound-guided regional. There are some ISURA guidelines, as you probably are aware, published in 2010, and they're helpful in terms of giving us a guidance for how to get trained and how to maintain training in ultrasound. But really, they're just level, level. In fact, I don't think it's level 1, level 5 evidence, which is just expert consensus opinion. It's not really, in terms of overall evidence base, it's not really high-level opinion. So have a look at this paper, because it is an important paper, published a couple of years ago now in Regional Anesthesia and Pain Medicine, and really just summarizing the expert opinion to date on how to get trained and how to maintain training in ultrasound-guided regional anesthesia. And basically, a number of key factors discussed within that paper, discussing how to understand image generation and device operation, and I'm sure many of you have been looking at that within the course over the last few days. Understand how to optimize the image, obviously very important, and then understand how to interpret sonoanatomy and acquire the necessary hand-eye coordination skills. And in terms of the basic skills for ultrasound, I would say there are 3 components. There's the operation of the machine, knowing how to operate it and optimize the image. There's the sonoanatomy knowledge, knowing what the sonoanatomy is and what you're looking at. Then there's the hand-eye coordination skills. And then the final thing is putting them all together. And what's most important? We don't really know at the present time which of those components is most important, but they're all pretty important in terms of overall being able to practice ultrasound-guided regional. So 2 pathways to acquiring these skills that was discussed in this paper, basically summarizing the recommendations for those already in practice and recommendations for trainees. And I'm just going to talk really about recommendations for those in practice already. This is very similar really to where laparoscopic surgery was 20 years ago. And laparoscopic surgery went through these same debates and quandaries about how to train and how to train practitioners who were already in practice and ensure that they were safe. And they went through 3 levels really, or through a number of different types of training for laparoscopic techniques. And they started off with talking about preceptorships, and certainly we have a number of preceptorships in ultrasound-guided regional anesthesia at the present time throughout North America, throughout the world. And you can go to a center that runs these preceptorships and see ultrasound-guided techniques performed by experts. But one of the more important things that I've taken away from some of this literature is the role of proctorships, where experts actually go into hospitals of individual practitioners and actually supervise people performing ultrasound-guided regional techniques in their own environment. And I think there's a bit of a barrier at the moment between the preceptorship level and the final competence level. And certainly I know of many people that have spoken to me at workshops over the years and have said, look, I've done a workshop, I went back to my hospital, I tried to do a few techniques, but I just didn't feel comfortable. And so the machine went back in the cupboard again. And I think, I don't know of a great number of proctorships or a great amount of proctoring that's going on in ultrasound-guided regional, but I think that is one important area that we do need to focus on in the next few years. So what about recommendations for those in practice that came out of that ISURA paper? Well, attend a recognized CME event, which you're all doing. Attend a preceptorship, so you actually see blocks being performed on patients and understand how to do them in the best way possible. Practice ultrasound scanning techniques, so you can do that in many different ways. There are people that inflict ultrasound on their children at home in the evening, and relatives, etc., etc. You can scan yourself in the operating room. You can even scan your own patients when they're asleep in the operating room. You can practice needle insertion techniques on various different phantom models. One of the best ways of doing that is you can get yourself on a course that has a cadaver workshop where you can actually place needles on cadavers. It's a very nice way of developing skills in those areas. And then use a proctorship or employ a local expert as a departmental resource. So a number of departments in Ontario and throughout Canada in the last few years have actually, they've taken a new member of staff who's done a fellowship in regional anesthesia, particularly with an expertise in ultrasound, and then they've employed that person and used them as their local expert, the go-to person for when they may want some advice or some supervision with performing a case. And then continue to attend CME to maintain your competence in those areas. In terms of learning ultrasound-guided regional anesthesia, there are a number of ways to do this, but the way that I often suggest to people is to start off with your pre-existing nerve stimulation techniques. For example, an interscalene block at the Winnie technique in the interscalene groove there. Use your standard nerve stimulation method and just put the ultrasound probe on and watch what you're doing with your needle as you're advancing your needle, using your nerve stimulation endpoints to guide your technique. And when you get your stimulation endpoint, have a look at where your needle tip is and what the local anesthetic spread's like. And then you can start to understand the sonoanatomy, understand what's happening when you're injecting local anesthetic. And over time, you slowly convert to using the ultrasound endpoints instead of using the nerve stimulation endpoints, to the extent that eventually you'll actually get times when you're right on the nerve with the needle with ultrasound, and you'll know that despite having a negative nerve stimulation endpoint that you're in the right place and you'll continue to inject anyway. We often use peripheral nerve stimulation in combination with ultrasound, especially for our deeper techniques, and I was talking about that a little bit on Friday. So like I say, initially use your peripheral nerve stimulation and ultrasound. You probably early on you'll be using the peripheral nerve stimulation endpoints as a sort of trusted endpoint that you've used for many years, with the ultrasound endpoint as a sort of more of an observation of what's happening when you start to inject your local anesthetic. An example of that might be an out-of-plane approach with the popliteal block, where you're basically using your standard insertion method in the popliteal fossa. When you get your nice plantar or dorsiflexion twitch, then you can actually have a look with your ultrasound, see what the local anesthetic spread's like, and you start to understand the anatomy in the area. And there you've got a nice image of the tibial nerve in the popliteal fossa. Over time, like I say, you start to become more and more comfortable with your ultrasound endpoints, to the extent that very often, in about 25% of cases, in fact, you may well see your needle right beside the nerve or even impinging the nerve, but you can't get any stimulation endpoint. And in those cases, when you reach a certain comfort level, you'll know you're close enough. You can inject your local anesthetic without the nerve stimulation endpoint. And really, at that point, you've you've achieved a goal in terms of learning ultrasound-guided regional techniques, because you really are so comfortable that you're willing to take the ultrasound endpoint instead of the stimulation endpoint. And there's a typical example from popliteal block. We're using an in-plane technique across the popliteal fossa, predominantly with ultrasound endpoints. And there's a sonogram just illustrating that perineal nerve, tibial nerve, with the needle coming in beneath that structure. I do think there are many of us here that will regard themselves as experts in regional anesthesia, and but there are many of us here that might be starting to try regional anesthesia or ultrasound-guided regional anesthesia for the first time. And I think we make a mistake in our subspecialty anyway of trying to insist on too high standards early on in terms of what we're trying to see. An example might be an axillary block, where some experts insist that you have to be able to see nerves in order to do an ultrasound-guided axillary block. I don't necessarily think that's true. And I think simple techniques that every anaesthetist can use have a lot of benefit. And I've got colleagues in my own centre who don't do brachial plexus blocks very often, but when they do one, they use a technique in the axilla where they place local above and below the artery, and they get a very high success rate. I think it really reduces the barriers to learning, because I think when you try to aim for too high a standard early on and you fail at that standard, it's very easy to get put off very quickly and just put the machine away and not use it again. And we do need continued research as to best practice. Now, a good example of one of these simple techniques is, if you have a chance, go and read this paper by Brian Seitz and colleagues from 2006, published in Acta Anesthesiologica Scandinavica. And what he basically did was he took 50 odd patients, having hand surgery with axillary block, and he randomized them either to a standard transarterial block, which is what we used to do at our own center for many years. We transfixed the artery and placed local anesthetic behind the artery. So he did that in half of his patients, and in the other half of the patients, he used an ultrasound-guided perivascular technique where he just put local above and below the artery and looked at the different endpoints between the two techniques. So 56 patients, ultrasound-guided perivascular or transarterial technique, 30 mils of 1.5% lidocaine with epinephrine above and below the artery, just looked at block onset time and success. So what he was basically doing, this image of the axilla, you can see the axillary artery here, basically, and we've got the nerves around the artery, so we've got the median nerve, the ulnar nerve, and the radial nerve just sitting behind the artery there. And then what he did was he put local above the artery, put it below the artery, surrounding those nerves in the axilla. And the interesting thing is he didn't try and specifically block the musculocutaneous nerve, but I think what you get sometimes, especially with a higher volume technique, is with the median nerve, you get spread up the nerve to affect the lateral cord as it's coming down into the axilla. And with that technique, he had a very high success rate. And you can see here that with number of failures or supplementation, with the standard transarterial technique, he had something like a 46% failure rate, which is very high. But with the ultrasound-guided technique, 17.9% failure rate. But the number of patients who actually needed converted to general anesthetic was 0 in the ultrasound-guided group versus, what is it, something like 15% in the transarterial group. So really showing you can have a very high success rate with a very simple technique. And I think that's important for practitioners that maybe don't do ultrasound very often. Another very similar paper from Montreal, from Détran's group, very nice paper where they basically just randomized patients to either having a sort of high-level ultrasound-guided axillary block where they tried to pinpoint all 4 nerves and place local anesthetic around all 4 nerves, or they just looked at the musculocutaneous and then injected around the musculocutaneous and then injected behind the artery and compared the two groups. And once again, very similar success rate in both groups. So just demonstrating that you don't have to use the highest level of, or the highest standard of technique for many of our ultrasound-guided regional blocks. So just to change the subject slightly, what about buying equipment? Well, I'm not going to go into different manufacturers and things like that, but it really just depends on your type of practice. The more academic units may prefer equipment where you can manipulate the image or where you can optimize the image to a greater degree, especially if you're recording images or recording video. Where the less academic units may prefer more portable equipment with fewer settings that's maybe easier to use for the occasional user. So really it's just a matter of going to the different manufacturers and trying their equipment, asking them to come to your hospital and demonstrate the equipment and have you be able to use it in your hospital just to see the strengths and weaknesses of the different manufacturers. What about optimizing the environment for regional anesthesia? Well, this is probably one of the most important areas, not just for ultrasound, but for regional anesthesia as a whole. So I think, I've got it second here, but I think this is probably one of the most important things of the lot, is the strong anesthesia leadership. If you haven't got a chief of anesthesia or a cohort of very active practitioners in your group that's going to be able to support you when things go well and when things don't go so well, it's going to be very hard to maintain that practice. Because I think in what I've seen in my practice anyway, sometimes the strongest critics of regional anesthesia can not just be the surgeons or the physiotherapists or the nurses, but your own anesthesia colleagues. So I think you've really got to have very strong leadership saying, yes, we believe regional anesthesia is the way to go for this population of patients, and we're going to follow these patients very closely and make sure our standards are very high. We will have occasional setbacks, but we know from the literature that it's the right way to go, and we're going to maintain that practice. You do need to build a cohesive team of local experts. It's very difficult to practice regional in your centre on your own. Not so much, like I say, when things are going well, but sometimes when you need advice or when things, when you've got a complication, it's nice to have a colleague to talk with or fall back on and get their advice on different areas. Use a team approach to optimize outcomes with anesthesia, surgical, nursing, and physiotherapy input. So a good example might be in our own practice, the use of continuous femoral blocks for total knee replacements, where it's very easy sometimes to get into difficulties with excessive motor block and other problems. If you work in a team approach focusing on things like rehabilitation outcomes as we do, then it becomes much easier to bring your colleagues on board. And careful use of regional anesthesia in appropriate patients. I've heard people doing, for example, lumbar paravertebral blocks or thoracic paravertebral blocks for things like knee arthroscopy and things like that. And I think you do have to, although I'm a great believer in the benefits of regional anesthesia and where to place the place of regional anesthesia in practice, I think when you use it in the wrong environment, it can be very damaging. And then the last thing is careful patient follow-up, especially with regards to side effects and complications. We're not just block doctors. We're not just there to put blocks in and walk away. We're there to carefully build the type of care we're performing for our patients and then following those patients very carefully post-operatively. And I think when you do that for patients when things go well and also following patients who have complications very carefully, you'll build the trust of colleagues with your practice of regional anesthesia. And I haven't talked really about the use of a block room, but that is a very important area. It's not something that a lot of us have, I know, in terms of practice, but especially when you're learning regional anesthesia techniques, it is a great benefit to have a separate block area where you can perform regional techniques outside the operating room. We used in the past the recovery room in one of the hospitals where I trained in the past, and that was also a very nice area for doing blocks, where we placed blocks before surgery. So just in summary, to summarize the whole talk again, so the evidence base for the use of ultrasound in practice is very strong. There's many studies out there now demonstrating the benefits of ultrasound over other techniques for many regional anesthesia techniques. But the main barriers to use include training, include the availability of equipment, and probably most important of all, the environment that's conducive to learning and practicing ultrasound-guided regional anesthesia. Thank you very much.